I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and peri-menopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. Hello, listeners. It's Dr. Fiona Lovely and another episode of the Not Your Mother's Menopause podcast. And, it's such a cool part of my job that I get to meet amazing people. And I feel like every guest that comes on the show is somebody I just want to hang out with. And I have to say that Dr. Mary Jacobson, who is the interview I share with this episode, is just one of those people I would like to sit in a room with and just learn from. She is definitely one of the wise women that we need to spend some time with. So I'm going to read her bio, and then I'm going to tell you a little bit about what it is that she and I spoke about. Mary Jacobson, fondly known as Dr. J, is Hello Alpha's Medical Affairs Officer. Dr. J received her medical degree from Georgetown University School of Medicine. She is an accomplished academic, board-certified obstetrician and gynecologist with extensive experience in clinical care, medical education, hospital operations, and research. She completed her residency and fellowship at the Stanford University School of Medicine. In her free time, she enjoys stargazing, yoga, and baking bread. Dr. J is committed to making Hello Alpha the first stop for our patients' healthcare needs through our accessible and synchronous telemedicine platform. She is licensed in all states where Hello Alpha treats patients. So she and I had this sort of broad-ranging, robust conversation where we spoke about everything from what's great in the medical system and what is broken in the medical system, and how she suggests changing. And she says there is much reason to hope. There is a lot of change that's happening on this front towards whole person care instead of cutting people up into pieces and parts, meaning, this is the thyroid specialist, this is the brain specialist, this is the ovarian specialist, this is the diabetes specialist, or lungs or kidneys or hearts or whatever. That this whole person care is very much the way forward, and it's already showing up in med schools, which is great. I mean, she talked a lot about how medicine really is about being reactionary instead of looking at how we can prevent what we're seeing in the hospitals, etc. And, acknowledges that there is a problem with equality when it comes to female healthcare or women's healthcare. And accessibility is a problem too, especially in the United States, which is where she practiced. And dear listeners, I know many, many, many of you are in the United States. So hopefully this gives you some hope about the system and, where it can go. And, it just, wow, we just talked about so many things. It felt like one of those conversations that could have gone on all day. She talked about her time working labor and delivery in obstetrics. She talked about the 10 different stages of a woman's life and how social, cultural, and economic factors affect menopausal symptoms. Man, we talked about it all. But, I think one of the more interesting, God, it was all great, but I loved the part of the conversation where she shared, because she has been practicing long enough to have seen what menopause care looked like before the Women's Health Initiative, and then the release of the results of the Women's Health Initiative in 2002 and what that did to her patient care and to her practice. And then coming essentially full circle and seeing what menopause care is like now. You know, we did talk about Hello Alpha, which is the telemedicine platform that she is the medical affairs officer for, and how it levels the playing field for accessibility. It's a low-cost option for you to have medical care in the United States, for it to be personalized for you. We talked about how the process of being one-on-one in women's healthcare can be very intimidating for a lot of women, and how the telemedicine platform really sort of levels that playing field, and there isn't that power differential in how she refers to it. I think that's a great way to refer to it. So, and that's ultimately what it is. And I know I've learned that in my own work too, is that there's a lot of women that would prefer to be in a group program rather than be one-on-one care with me, because somehow that feels confrontational or just too intimate, especially to talk about the things we talk about. And I totally get it. I mean, we are operating at this time in our society. A lot of us are operating from childhood traumas that are being healed slowly or not even yet being acknowledged. And that's totally fine. I know for me, I have a deep interest in showing up in a way that can be accessed by anyone. And ultimately, that's what this show is here for. So please dig in and listen to this conversation that Dr. Mary Jacobson and I had. I so enjoyed it. And I literally feel like I'm gathering all these amazing souls from corners of the universe to come together and share with you, my sweet listeners. I almost said gentle readers again. Oh my goodness, I'm obsessed. Clearly, I'm obsessed. Bringing these amazing voices together to talk about the state of women's healthcare. So listen in and with an open heart and just hear from Dr. Jacobson, who has been in the trenches of women's healthcare in the United States, who has been innovating and researching and caring for women in this system for a long time. She is one of the wise ones. So listen in, and I hope you enjoy this conversation as much as I enjoyed having it. Thanks for listening. It's important to me that the supplements I use are of the highest quality, and that's why for more than 3 years I've been drinking AG1. It is researched and developed by an in-house team of scientists, doctors, and nutritionists with decades of experience in their respective fields. Quality for AG1 isn't just a buzzword, it's a commitment backed by expert-led scientific research, high-quality ingredients, and rigorous testing. I know I can trust what's in every scoop of AG1 because they obsess over product quality, the standards of manufacturing partners, and sustainable practices. It's easy and fast to use. Drinking AG1 mixed with water in 1 scoop a day covers my nutritional bases. Prebiotics, probiotics, digestive enzymes for gut support, B vitamins and rhodiola for energy support, folate, magnesium, and ashwagandha for stress support, and vitamin C and zinc for my immune health. So if you want to replace your multivitamin and more, start with AG1. Try AG1 and get a free 1-year supply of vitamin D plus K2 and 5 free travel packs with your first subscription at drinkag1.com/Fiona Lovely. That's drinkag1.com/Fiona Lovely. Okay, listeners, this is Dr. Fiona Lovely in the Not Your Mother's Menopause podcast. And I'm thrilled to be in the person with Dr. Mary Jacobson of Hello Alpha today. Welcome to the podcast.
Thank you, Dr. Lovely.
My pleasure to have you here. It really is. So you are the medical affairs officer for Hello Alpha, which is one of our telemedicine platforms we have for women's care. Is that correct?
Yes, it is.
I love it. Can you tell us a little bit about Hello Alpha, please?
Sure. Well, at Hello Alpha, we want to revolutionize care for women. We believe in health equity for women. And as you know, in the United States now, and for a while, there has not been equitable care for women. And I practice a holistic approach, different from yours, Dr. Lovely, but nonetheless, thinking about the whole person. And when we talk about menopause, when we talk about women's reproductive life, the 10 stages of reproductive life, how do hormonal changes, how do neurochemicals impact medical conditions, impact stress, impact quality of life in these milestones that females at birth, and when I say women, I mean females at birth, go through, starting at menarche up until late menopause.
Fantastic. I think you've just said more to me from the sort of medical point of view than I've heard from a lot of other doctors who are in the space. Like you are able to drill. Now, how much of that did you learn in school versus practice for many years versus putting together treatment protocols for Hello Alpha?
So definitely building blocks over time, Dr. Lovely. With respect to my training in medical school, it was really focused a lot on labor and delivery and maybe scrubbing in for some hysterectomies. It wasn't a lot about seeing patients in the office, knowing them as people, again, thinking about the whole person. And I can tell you for OBGYNs, the weakest part of training, but it's because we need more experience, is office gynecology. So over time and through my patients and obviously lifelong learning, I learned to care more appropriately for my patients, especially for their gynecologic needs. Where I saw a gap and where Hello Alpha came in as well is OBGYNs, new OBGYN, primary care doctors like family physicians and general internists knew various medical conditions like asthma, migraines that I really didn't know much about. Oh, you have a migraine, go see your primary care provider. Oh, you have menstrual cramps, go see your gynecologist. And there are a lot of gaps in that type of care and a lot of disparate care. And I really saw that as a niche for Hello Alpha. And that's why we focus on providing, again, whole person care by experts in women's health. So now you asked me my journey over time. I've been practicing primary care, Hello Alpha, for the last 5 years. And I have a great understanding of migraines, how migraines increase in the peri-menopause, autoimmune diseases
Mhm,
increase, flares increase in the peri-menopause, rates
mhm,
of anxiety and depression in boys and girls are the same. And then once menarche hits, women have higher rates of anxiety and depression. Perinatal anxiety and depressive symptoms are the most common complication in pregnancy, and these symptoms can last up to 3 years after delivery of a baby. So, and then thinking about patients, let's talk about pregnancy with a history of preeclampsia or with a history of gestational diabetes, they're at higher risk of cardiovascular disease and diabetes later in life. But 40% of women don't attend their postpartum visit. So they may not have an opportunity for education and for thinking about prevention. And then they may come back into the healthcare sphere, 20, 15, 20 years later, right? Because they're focused on their children with these disease processes that have unfortunately may have gained hold, right? Because the risk of developing type 2 diabetes with a history of gestational diabetes is about 50%. So, and thinking about what my role is as a gynecologist, as a physician, thinking about the whole person and not just treating
mhm.
pregnancy, see you in a few years, and like I said, gynecologic conditions.
Interesting. Well, and I think women are having babies a lot later in life than, even a few generations ago. And so now you're, I'm sure, seeing the overlapping of prenatal care with perimenopause. I mean, I've seen certainly that in my patient care. I have a friend who was pregnant at 47 and had her baby, and her periods never resumed after that. So I think there's probably even a fairly interesting conversation to have there.
Yeah, I totally agree. And obviously, as we age, we may have more medical conditions, and that increases risks during the pregnancy as well. Not to mention, at 42, getting pregnant, if you're using your own eggs, there's a high rate of miscarriage. It's up to about 50%.
Mhm.
And then higher rates of preeclampsia. I mentioned that before. And that's a disease that's usually marked with high blood pressure, as well as kidney disease, potentially, and a clotting disorder in pregnancy. And I already
Mm,
mentioned an increased risk of cardiovascular disease. So I had a
mhm.
patient that I treated at Stanford. She was a long standing patient of mine, and I took care of her during her 3 pregnancies and followed her. And she had a family history of her mother with cardiovascular disease in her early 50s. And they had a family type of high cholesterol. And I had to work with the cardiologist when she got pregnant again, even though the cardiologist said, you know what, maybe you shouldn't get pregnant because you cannot use cholesterol lowering medications during pregnancy because of the impact on the pregnancy and the fetus. So talking to her about risks and benefits, stopping the cholesterol lowering medications, following her throughout the pregnancy with a cardiologist following along as well. So,
I love this. You're ultimately saying what you talked about was that whole person care, that whole person approach, which is very much missing from Western medicine, allopathic medicine, traditional medicine, whichever word you want to use. And I actually have a quote from you that I'd like to read because I'd love to hear your thoughts on it further. So you said, our medical system still has challenges because of a lack of understanding for whole person care, meaning there isn't enough education and accessibility to preventative care. This goes back as far as medical school training. Preventative care and women's health focused studies is unfortunately still a rarity in medical school training. Can you talk more on that, please?
sure. So, in Western medical education, well, I can speak pretty confidently in the United States. When you think, or when you just go to a healthcare institution, the Department of Neurology, the Department of OBGYN, the Department of Cardiology, this, that, and the other. So we cut people up into different parts of the body. So the way it's set up, where we go to get our health care, the way it's set up, where we go through rotations as medical students through these different specialties, already compartmentalizes the person into a set of diseases. And you're already looking at the person almost in blinders based on what your area of expertise is. I want to share another story with you of a patient, and this was not my finest hour. So I did a fellowship in minimally invasive gynecology. So I treated patients for endometriosis, fibroids, infertility. So I did a lot of surgery. And I had a patient who was following me for fibroids, did a history of lung disease. It was called pulmonary hypertension. And so she was also co managed by a pulmonologist. So she'd see me every 3 to 6 months for fibroids and then see the pulmonologist for her lung function. So one visit, she came to see me, Doc, I have this lump in my breast that I'm worried about. And okay, I've been focusing on the pelvis for several months now. And I looked, at her breasts without even examining, and she had a fungating mass that was oozing, and she had an obvious breast cancer. And here she'd been diligently following with me, the gynecologist, right? And here in the United States, it seems crazy, but here I'm focused on the pelvis because I'm a pelvic surgeon. General surgeons do breast, right? She's not seeing me for a preventive health visit. The pulmonologist is listening to her lungs. By the way, the lung fields are in the chest, the anterior chest. Anyway, that really, really shed light on that concept to me, Dr. Lovely,
Mhm.
thinking about how am I treating this patient? This is a whole person, and I missed this cancer that I may have been able to diagnose months earlier, and she would have had a better, quality of life and outcome. So that was really mind blowing to me and really impactful in terms of how I practice medicine since that time.
I bet. And it's brave for you to talk about it. And I find it so interesting because I talk to experts of all kinds, but especially in the Western medicine traditions. So often do I hear stories just like you just told, which is, I did this, I went about being the gynecologist, the urologist, or whatever, and then a patient came along and changed my mind. So often this is the case. And I know I've heard the term bikini medicine is ultimately how you're educated as a gynecologist. Anything that's underneath the bikini is what you take care of. And I think that is a very incredibly narrow. I mean, we know that now. It's a very incredibly narrow. Women's bodies are so complex, which is why I think it was easy for medicine and research in particular just to say, too hard. We're just going to leave you out for a long time. So sorry you had the experience of that, and I'm also grateful you had the awakening of it, and thank you for sharing.
Sure. And I wanted to touch on, Dr. Lovely, something from my quote that you mentioned. So, we in Western medicine, we're not good at preventive care. We get little to no training on diet, as an example. We talk about social determinants of health, but we really don't incorporate them well when we're treating the patient in the office. It's either an afterthought or it's a screen that we don't really deal with. So, we have a large percentage of patients who suffer from food insecurity. They may have not access to shelter periodically.
Mm.
They may live in an environment that is unsafe, where they don't have parks, where they don't have access to fresh produce, and that really is a part of health and wellness. We're focused on diseases in Western medicine and treating the diseases and being reactionary. And I think that that's still pretty much the case. Also, and I hate to be negative, but just truth be told, we have a shortage of primary care providers in the United States. They're placed in areas around big cities and suburbs of big cities, and rural parts of America have actually lack of access to care for even primary care providers. About 50% of counties in the United States do not have an OBGYN. So there's a problem with access to care, which for primary care providers, the gap is being filled by advanced practice providers, nurse practitioners, and physician assistants. But, this trend of fee for service or being paid more, basically more for procedures and less for caring for the whole patient for
That's a
primary
problem.
care, right? Major
Yeah,
problem. And I
yeah.
think that needs to be addressed because people see, I want to make a lot of money. I have a lot of debt from medical school and I want to work, Monday through Friday or what have you as a dermatologist, as an example, or an ophthalmologist. And I think I'm going to apply to that field instead of I'm going to be making maybe $100,000 a year if you're a pediatrician. So it's a life choice as well. And when I went into medicine, Dr. Lovely, I was very optimistic, thinking, I really care a lot about people. I actually was in the mutual fund industry initially, and that was in the late 80s. I lived in San Francisco when AIDS was raging. I lived in the
Mm.
Upper Castro. I did volunteer work through Project Open Hand, delivering meals to people with AIDS. I had a lot of friends who had AIDS. In fact, one person specifically who has encouraged me to go to medical school as I was struggling with, wow, I'm not really fulfilled with making money for people, and I'm really fulfilled doing this volunteer work. Anyway, his name was Bill, and he actually was getting ready to go to chiropractic school. And he was very smart and he was very encouraging for me in my career, giving career advice, even, on his deathbed, basically. And that was another pivot for me with respect to, going from Wall Street essentially in San Francisco and then going into medicine. I think I'm getting off on a tangent, Dr. Lovely.
No,
Sorry about that.
please don't. I love your story. It's so inspiring. I thought, as you were talking, I thought, oh my God, I don't have a tissue nearby. I mean, I need to have a tissue. I'm going to use my sleeve next to dab my eyes. We lost so many brilliant, brilliant people, beautiful souls in the 80s to the AIDS epidemic. And sometimes I look back on that now. I was very much aware. I was a young woman, and still in high school, but very much aware what was going on, seeing how we are now versus then. I don't think my gay friends back there could and me could have seen what has happened in terms of acceptance and inclusion. And yes, I think Dr. King, when I have these kinds of conversations, because there is so much darkness in the world right now, and I have to remind myself, if I happen to be silly enough to look at the news for a moment, that the rising of the dark also means the rising of the light, because those two things go hand in hand. So I thank you for talking about that, because what came to me was that you stepped in to your training with this enormous heart. And I'm going to guess that your training probably chipped away at that over time, just as it did for me. And, for you as a wise woman, looking back on that, do you feel profoundly changed by the experience of having practiced for as long as you have, plus the experience of medical school?
Oh, absolutely. Absolutely. I already mentioned my journey in terms of thinking about a patient as a whole person and walking in the patient's shoes. I practice mostly in my career in academia, and where we go after the zebras, I don't think about the
Mhm.
patient and where they are with respect to, we talked about social determinants of health and what's really realistic for the patient, and kind of just practice by the book. Well, the clinical data says this and the trial says that. And so that's kind of how I practiced medicine for a while. And I was very focused on education. So I was a associate residency director of OB/GYN at Stanford for a while. I was the chair of the American College of Obstetrics and Gynecology Surgical Simulation Committee for a while. So that was my focus, was really
Mhm.
education. And then I had another career pivot where I had a back injury that basically ended my brick and mortar career as a physician. And, then I became a patient, right? And then I went through a bit of a dark period for myself mentally, depression,
Mhm.
because I missed my patients and my educating people. Anyway, then I got a business degree at Stanford and a biodesign innovation degree. And I ended up working at an HHS for 4 years in clinical operations. So it was a different patient population than I saw at Stanford. People taking two buses to get to an appointment and bringing their kids to their appointment, right? Because they couldn't afford it. These are people who pick our crops in the Central Valley and do a lot for us, and thinking about how we can deliver care better and more equitably to people in general. And anyway, and then I ended up at Alpha, at Hello Alpha. And obviously, with my background in women's health, working on health equity for women, I'm going in a big circle, getting back to that quote. So there's still a lack of training with respect to women's health. I already mentioned about women's health isn't just below the bikini line, as you mentioned. It's not just bikini medicine. And there's a movement, I'm happy to say, in graduate medical education to bring in whole person care, to think about people as whole people, not as the diabetic patient, but the
Mhm.
patient with diabetes.
Mhm. Mhm.
Unfortunately, there's still quite a bit of stigma and dismissiveness that exists, particularly with women with symptoms. The rate of cardiovascular disease in men and women is the same postmenopausally. Premenopausally, it's much higher in men than women. And, we providers, physicians, we miss signals with respect to a heart attack or cardiovascular disease in females at birth. Oh, it's anxiety. It's, you know, don't worry
Mhm.
about it. Why are the
Mhm.
rates of mortality or death after a woman has a heart attack within the first year a lot higher than men? It really falls back on not getting diagnosed early and treated. So I still see that's one example of health inequity. You mentioned research. We talk about research and we have guidelines about including women in research, including pregnant people in research, but we still have a long way to go. We still have a long way to go, even with bench research, with respect to, sex assigned to the animal, what have you, and what the impact that has on disease processes. So there's still a long way to go, but I agree with you that there is a light.
Mm.
And
Thank God.
yeah, exactly.
Yeah, yeah. So you've touched on something I think that is so important to talk about, which is that cardiac risk factor between men and women. How, women generally overall are healthier until we reach menopause. And then our health declines. And in a lot of ways, we meet the risk that men have. And so, for a lot of years, we have been looked at as little men, like our bodies as little men. And you and I both know that couldn't be farther from the truth. And I think sometimes that's what makes it difficult to study and create protocols, et cetera, for women's health, is because we are all so different and have such different presentations that, if HRT is appropriate for one woman in one format, it's going to be very different for another woman in maybe she can do the oral estrogen or the bioidentical progesterone versus the progestin. These sorts of things are the conversations I think are really important that we're having them. And I'm loving that it's women creating these changes, is really what I see. Or at least it's those of us out there talking about it, is what I see. And we finally just went, and I think it's our generation too. Like this Gen X ladies were just like, hell no, we're not going quietly into the night. Mm-mm. No, you're going to fix this and I'm going to help you, and all of the things, right? And it'll be so much better for the generations behind us, our daughters, our nieces, our cousins, etc., which is a very good thing. I know my grandmother had a heart attack in, what year was that? 2001. And it was missed. All of the signs ahead of time were missed. And, even when she went to the emergency room, they still thought it was, indigestion. So, I'm glad that is being seen. And we know now that women present having a cardiac event very differently than men do. And thankfully, we know that now. And we're just learning through all of it. So, I have essentially two questions I want to ask you about the things you've just been talking about. First, I want to ask you, how do we go about fixing the problem of the pieces and parts method, the silos method of how our doctors are taught? How do you think we go about fixing that?
I think it's going to have to start with medical education. And Dr. Lovely, it has started in the United States. So the
Wonderful.
ACGME has set guidelines with respect to medical education in general throughout all the medical student as well as residencies. So now, at least at Stanford, and I don't think this is widespread, but leading academic institutions are knitting things together when during the training of the medical student. So now they're not just focusing on one system without understanding the other system. So when they do a rotation in OBGYN, remember I mentioned preeclampsia, then
Mhm.
they'll learn more about cardiovascular disease and the risk of stroke in a patient with a history of preeclampsia and pregnancy and hypertension, and how we can help prevent or educate the patient about these disease processes, as well as understanding the physiology around that.
Mm.
So I do see a light with respect to bringing concepts together in training instead of
Wonderful.
having each on its own trajectory.
Wonderful, wonderful. I love to hear that. That I hadn't heard anybody say this before you did, that the working Monday to Friday as an ophthalmologist or a dermatologist and making a great deal more money than if you're working 7 days a week, potentially on call as a pediatrician when you've got hundreds of thousands of dollars in student loans, etc. And you've been paid poorly for your first few years in your, residency. Something needs to change about that too. How do you go about making it? I mean, I look at what my GP does and I'm blown away at and most of what she does is refer. I mean, she treats the things in the office that she can treat, but she writes her work is admin. And I think whatever you're getting paid, sister, it needs to triple.
Right. I agree. I think it's going to have to be at the federal level, Dr. Lovely.
Mhm.
I don't see any other way around that. And, the fee for service model, that's favoring procedures, over seeing a patient in the office and getting a full history and talking and listening to the patient. So I think that needs to be restructured. Some of my capitalist colleagues may not be happy with what I just said, but to me, that's the bottom line.
Mm,
And then I think you'll see the change happen with respect to more people going into primary care.
mm,
Right now, our solution, like I mentioned in the United States, is to have physician assistants and nurse practitioners help with that lack of primary care provider coverage across the country.
mhm, mhm. Yeah, we see that here in Canada as well. So we do have a deficiency of primary care physicians here as well, and that doesn't seem to be getting any better. And again, we're just it's probably exactly what you talked about. You can go into these specialty. I mean, if you have the ability to keep going in your training, et cetera, and you want to go into these big specialties that take years more training, then you're drawn to it. You and I both know you're drawn to a specialty or you're not. But what we're seeing here in my city is that the GPs are really getting all of these questions about how to prescribe hormone therapy, but most of them were trained in the era of the Women's Health Initiative, which is these things are risky, here's antidepressants, or go get some acupuncture, or relax, take a bubble bath. You'd never say those things to men, right? I mean, this is the era we're in. And so what I've seen in my city is the nurse practitioners are picking up the slack there. Now, they're outside of the system, so you have to pay privately for them, which
Mm.
of course we're socialized here in Canada, so our medical needs are covered for the most part. But if I want to upgrade, it's kind of a two-tiered system a little bit in some of the provinces, not all of them. And the nurse practitioners seem to be the ones that are picking up the slack. But I'm concerned when I refer my patients to the nurse practitioners because the GP has been unable to help. Who can really afford that? At a time where groceries and gas for your car and utilities are never been higher. Who can afford the 400 to $1,500 intake fee for the nurse practitioner? So I think a lot about accessibility. And we haven't seen the telemedicine platform pop up in Canada yet that I know of for menopause care in particular. But I love the concept of Hello Alpha, creating this, like just leveling the platform, making it affordable, certainly far more affordable than I've heard the premiums can be for healthcare in the United States. So I'd love to hear your thoughts.
Sure. So I think telemedicine will revolutionize healthcare. It's just a matter of time, in my opinion, as generations who are very tech savvy age out, as we get more data with respect to telemedicine. I mentioned before, Dr. Lovely, only 50% of the counties in the United States have OBGYNs. And by the way, that number is going to decrease, right? With abortion being illegal in a number of states And OBGYNs going into residencies there, they're going to have a hard time filling those slots because those OBGYNs aren't going to learn that skill, and they want to learn that skill in
course,
general. Or
of course.
OBGYNs are leaving those states because they're afraid of getting into litigation for treating a patient appropriately, for providing whole person care, for providing all reproductive health care for women. So when I think about telemedicine, I think it can help fill that gap where people may not have access to care, or like you mentioned, for a brick and mortar visit, it's really, really expensive. So for telemedicine, it's convenient for people too, right? They can do it from their own home, a visit. We actually practice mostly asynchronous telemedicine. So our communication with patients is completely in writing at Hello Alpha. So patients complete a medical intake form, let's say for menopausal symptoms. We get an entire history. We get an idea of what the patient's primary symptoms are, as well as where they've been with their symptoms and how they would like to be treated. And then we have a conversation. Again, everything's in writing. That's what one of the ways it makes it more affordable, as well as convenient for the patient, by the way.
Mm.
And then we gather all this information about the patient. We understand what their cardiovascular risk is, if they're interested in systemic estrogen therapy, as an example, and we treat them. So it's a lot less than $400 to $500 a visit. It's
Mhm.
anywhere from $30 to $60 for a comprehensive visit.
Affordable. Yeah, for most
Absolutely,
people. Yeah, yeah, very affordable.
absolutely.
We live in a time of unprecedented stress and an awareness that this isn't a healthy way to live. But what can we do to signal calm and safety to our brains so we can feel happy, sleep better, and relieve stress? Long term health and longevity matter to me, and I use the Apollo to help. Apollo is a therapeutic wearable that works by sending gentle vibrations to the body that signals safety to the brain. It's a non invasive way to relax, get the sleep you need, focus attention, and get into that creative flow state. With consistent use, the Apollo retrains your nervous system, encourages recovery and calm, and relieves stress to help you feel better overall. It provides continuous support for mental and physical health, and I love it. Since I've been using my Apollo, my sleep is deeper and more restful, my HRV is higher, and I notice my days are spent in a calm and aware state rather than reactive and stressed. Apollo is offering 15% off for listeners of the show. Please visit apolloneuro.com/lovely. That's APOLLONEURO.com/LOVELY, or use the code LOVELY when you check out. Apollo is scientifically validated to show significant benefits. It even has an awesome stay asleep feature. It detects early signs of waking in the night and delivers gentle vibrations to keep you asleep. Check out apolloneuro.com/lovely for 15% off the Apollo wearable technology. So, I have some thoughts on telemedicine that I know that it was really the pandemic that opened up telemedicine in my mind anyways. Certainly that was true for my practice. But I practice hands-on. So I never thought in a million years I'd be doing telemedicine, but I actually found out that I could. But anyways, beside the point, I think somebody brought me this idea a few years ago and it stopped me cold, and went something like this. Women want care from you in, that well woman sort of situation. But for a lot of women, the one-on-one care face to face in the room is too confronting. And this speaks to the trauma that we've actually experienced, which is a huge conversation. The big T, the little t traumas, whatever they are, it's too confronting to sit and have somebody eyeball to eyeball and saying, how can I help you? And when I heard that, I thought, this is fascinating. And I think this is where telemedicine fits in a gap a little bit because there is a little bit of a distance. I have also heard that from some women in the States that have used the telemedicine platforms like Hello Alpha, that they can do it, they can hide in their car if they want to, they can do it at work. So there's a lot of, they can talk about things that may relate to maybe their primary relationship, things that they don't want to talk about while they're in their home. And I find that is a very interesting component of telemedicine. I'd love to hear your thoughts.
So, in terms of the power structure you mentioned in the office, it's there, right? I'm wearing a white coat today. You're vulnerable, right?
Mhm.
You're in the reception area. You may get weighed in a hallway in front of other
Mm.
people. You're
Mhm.
sitting there undressing with a thin gown on, waiting around for a number of minutes for someone to enter the room. And to your point, eyeball to eyeball, it's intimidating. You may not remember parts of the conversation if you don't have someone there as an advocate. Uh, so there's a big, I would say, a power differential in the office that does go away with the telemedicine visit, especially asynchronous visit. This is my hypothesis, Dr. Lovely. I haven't
Mhm.
tested it, but I'm confident that it definitely, I shouldn't say it goes away, but I think it's not, it's at least not as imbalanced as it is in person, and it is less intimidating. And I have to tell you, some of the feedback we've gotten from our patients, like patients with anxiety, I mentioned anxiety symptoms increase around the perimenopause and
Mhm.
menopause, giving us reviews about they're so happy that this is an option. I don't have to schedule an appointment. I don't have to look at you even on a video. And it's much less intimidating for me. And otherwise, I wouldn't have sought care for my anxiety symptoms. So I think
That's
it's
huge.
really powerful. Yeah.
That's huge. When you put it like that, it just I mean, there's no question in my mind. Initially, when the idea of telemedicine was academic rather than, this is how we do it when we're, primary care providers. I would have said, "Oh, there's a coldness, you don't get the warmth, whatever." And like I think about when you and I both came on the screen here a few minutes ago, I could feel your warmth right away. Like there was no barrier to that. And so I think how did you put it, as those who are less tech savvy sort of move along, spiritually, perhaps, shall we say, then we'll see more embracing of the telemedicine platform, which I just think is a really interesting thing to think about.
Absolutely. I mean, think about, kids these days, they do everything on their phones. They text. They don't want to call someone on the phone even, never mind make an appointment. I don't remember the statistics, but a lower percentage of younger people have a primary care provider. I mean, young adults greater than 20 do not have a primary care provider than older adults. And I think
This
part of that is because of, you know, it's inconvenient. I'm not going to schedule a visit. Why do I have to meet with this person and someone in person? I just want a prescription for, birth control or something like that.
Yes, I know that practicing female health in the United States is a bit of a powder keg right now. And I was just reading yesterday that apparently there was a vote about access to contraception for all women that had a number of senators vote against it, which just makes absolutely no sense to me. And I generally don't have any sort of political conversations on this show. There are other shows that are much better at that. Besides, I'm Canadian. I lived in the States for almost 10 years. I have an American husband, but so I know Americans pretty well, and I have American family, and I adore my family and my listeners, etc. But anyways, it's shocking to look in on it from the outside. And I think of every pregnancy scare I had as a young woman, even though I was using contraception. Who could I speak to? Was I terrified? Hell yes, I was terrified. Did
Right.
I want to go to my medical doctor? No, my medical doctor was the same doctor that saw my parents. I didn't want my parents. Like there was so many like mental barriers to care. And now there's actual barriers to a woman's right to choose what she does for her body. And I know that taking care of women's health is got to be. Did you ever think you'd see this time coming?
Absolutely not. To upscope, our democracy is under threat here in the United States. So that's pretty scary. And
Jesus, that's a
people,
statement.
yeah, and people have been positioning against Roe v. Wade and the Dobbs decision since 1973. And I think that some of us may have been asleep at the wheel during this time. And we didn't think that the Dobbs decision would be overthrown by the Supreme Court. And it was. And that's just the beginning, to your point, Dr. Lovely. So it's not just about abortion. And by the way, women don't get abortions as a form of contraception because they want to. It's a
No.
very difficult decision. And, some women, it's a desired pregnancy, but there's a problem with the fetus that they may have a lethal anomaly,
Mhm.
or there may be other problems that threaten the life of the mother. So anyway, so that's my spiel about that. And also, it is impacting care elsewhere. So, gender affirming care is under attack in a lot of states in the United States. We know in Louisiana, they passed a bill that made misoprostol and mifepristone, medications that we
Yeah.
use for medication abortion,
Mhm.
scheduled controlled substances, which really limits access to these medications. And I want the listeners to know that, a drug like misoprostol is used for different treatments for different things. We use it to induce labor. We use it to dilate the cervix before a procedure. We use it if a patient has a postpartum hemorrhage and is bleeding to death on labor and
Yes.
delivery. So, my point is that these medications, limiting our access to these medications, impacts all of us.
Yes.
Methotrexate we use to treat an ectopic pregnancy, to stop an ectopic pregnancy. We use methotrexate to treat patients with rheumatoid
Yes.
arthritis,
Yeah.
with different types of cancers. So this is a public health emergency, what's going
Mhm.
on with respect to our health rights in general. And I do find it very chilling, but I want to go back to your talking about a light. So, when we look at some of the states that try to pass these laws making abortion illegal, and seeing that the public in these states, like Kansas as an example, are overriding that, they want to have the right to an abortion. So, I think that that's a silver lining, because if you look at the surveys, about 70% or over 70% of American adults are for access to first trimester abortions in this country.
Mhm.
So, the way our political system works, though, it's a minority that's driving this initiative
Jeez.
against women's reproductive rights.
Uh, I think it's a problem that policymakers are making medical decisions. That's looking from the outside looking in. I remember my father saying to me years and years ago, I was asking him about some political thing that was happening in Canada. I was probably reading it in the news or something. And he said to me, he said, Canada is different in that we keep religion out of politics. And he said that's a really important distinction. And I was really too young to really understand that. But as I've gotten older, and as I have gone into, women's healthcare, even though I was never my intention, I love it. I didn't know how much I would love it, but and how satisfying it is. But that's always stayed in my mind. That's a really important distinction. I think if you're talking about democracy, then that has to be part of it.
Completely agree. I think that Congress and the Supreme Court and other federal courts litigating healthcare is beyond their scope of practice. And
Yes.
it's such a violation, Dr. Lovely, of the patient-provider relationship. It's disgraceful. It makes me almost cry because it
Yes.
really erodes trust in that patient-provider relationship, which impacts, by the way, the health and well-being of all of us.
Yeah, absolutely. Well, listen, if you're in charge of making decisions for everybody, you best know everything inside and out about that decision you're making. And only a medical doctor can make those decisions for a woman, between a woman and her doctor. Okay, so
Exactly.
let me just sort of, that's as political as I've ever gotten on this podcast. Although there was a day that I did record an episode on, there was a certain election day that kind of went sideways, and I thought, you know what, I'm going to record an episode on erectile dysfunction. It feels like I'm never going to have a boner again. I'm pretty sure there's lots of other people. Should I say lady boner? Is that weird? Anyways, okay. So putting all of that aside, thank you for sharing that. I know it's a difficult time for, especially for healthcare providers. So what I want to ask about is, you have been in gynecology long enough to have seen when women were prescribed hormone replacement therapy like Premarin, to see the Women's Health Initiative happen and us do a 180 on HRT. And then in recent years, very recent years, to see that 180 return. And now we're saying, no, 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 HRT is actually very helpful for women in the menopause transition. Can you talk a little bit about that, please?
So pre-WHI, we thought that, well, first of all, it was called hormone replacement therapy, right? Because the woman has a disease that we have to treat. And that phrase was promoted by Big Pharma, right? Because it advantaged them, Wyeth as an example, who
Yeah.
was the first maker of Premarin and Provera. And back then, we thought that this hormone replacement therapy improved cardiovascular or decreased cardiovascular events in women. And so we were giving it out basically like, well, I don't want to say like candy, but practically it was in the water,
Yeah.
you know, and we weren't screening appropriately. And I mean, we were doing the best we could based on the evidence that we had to work with. And then the WHI study came around, and that was a very well designed study, but you know, it had flaws. But nonetheless, we learned for sure that estrogen could increase the risk of cardiovascular events in certain people, right? People with a history of high blood pressure and a higher cardiovascular risk, as an example. And so that was a very important learning. But the trial was stopped prematurely because they saw a little bit of an increased risk of breast cancer in women who are on estrogen and progestin, which that was unfortunate that they did, but that's another sideline that I'll get to. And so to your point, Dr. Lovely, as soon as that data came out, our offices were bombarded with phone calls. Patients wanted to, what should I do now? Some wanted to get off medications. How am I going to treat my symptoms? And bad press everywhere about estrogen and progestin for treating menopausal symptoms. And then we got more granular about the data from the WHI, knowing that the only drug that was studied was Premarin or Prempro, Premarin, and Provera. So they
Mhm.
were pills. There weren't patches. There weren't sprays. There weren't gels. Um, it wasn't really that nuanced. And the average age in the study was I think, in the early 60s. That's
Yes.
the
Yep.
average age of the woman, even though women go through menopause 51 to 52 years of age. And by the
Mhm.
way, perimenopause lasts for 5 to 8 years. So we were lumping everyone together too. So fast forward today, you know, we've had a lot of studies looking at that and picking apart this WHI and doing other studies and knowing that, hey, you know what? Estrogen and progestin have a place for patients who are soon after menopause up until the age of 60. And that's when cardiovascular risk really increases. And I'm not talking about all women, Dr. Lovely. I'm just making general statements. So not only that, but now have great research, right? First of all women who make it to the age go through menopause, so it affects all of us in some way or the other. Vasomotor symptoms impact 80% of women. By that, I mean hot flashes and night sweats. So about a year ago, a great drug was passed by the FDA. And I don't have to get into the name of the drug, but the point is now we're elucidating the pathway in the brain that increases the risk, the rate of these symptoms. So now we have targeted medications that can help treat these symptoms. So we have hormonal agents that are still really effective for vasomotor symptoms. And now we have one non-hormonal agent that's very effective. And there's another one in the United States in phase 3 clinical trials that looks like it's going to be approved for not only treating vasomotor symptoms, but sleep disturbances around the menopause. Anyway, so that's like a fast, down and dirty journey with respect to post WHI. But in a nutshell, I think we're getting more sophisticated. We're understanding that menopause, that's several stages in the 10-stage reproductive life cycle of a woman, and the treatment is going to be different when we subsegment menopause over time.
I love it. I love it. There's so many things to say about that, and it must have been just fascinating for you to watch this, just like we talked about how, when we were spending time with friends during the AIDS epidemic, you couldn't have seen that it would have been a different thing. It's not dissimilar in how so different we've changed. We've been able to advance this, which is great. And like I said, I really think it's women driving this forward because we're unwilling to be told yet again, just go get a massage and take a vacation. I have strong words for that piece of advice. Anyways, so what do you think about? I get asked this question a lot. What do you think about HRT for women over 60?
Menopausal hormone therapy has to be individualized.
Mhm.
I think we really have to, and you talk about on your website, personalized care.
Mhm.
That's what we have to do for menopausal hormone therapy in someone at 60. Because again, not everyone's going to have a high risk of cardiovascular disease. And have you been on menopausal hormone therapy over this period of time? And why are you on it? Have you tried weaning off of it, and what are your symptoms, and how does it impact the quality of your life, by the way? Right, let's not just forget about that. So I think it takes a conversation with the person, reviewing all the information, and for the person making an informed decision. So I wouldn't say carte blanche at 60. Okay, that's it. I'm not writing another prescription. I think you really have to work with the person with respect to what their goals are and
Mhm.
figure out the best, safest way to address their goals and their needs.
Mm. So you're saying it's possible, but it depends on a lot of factors. We need to make sure we've got a proper history and exam on you. We need to make sure we know what measures you may have used at this point. And I have heard that the
Exactly.
cardiovascular risk is sort of the biggest thing to look at once we get over the age of 60, etc. We're learning a lot too about how to take care of our brain health at specifically around prevention of Alzheimer's and dementia, and whether HRT plays a role in that too. And I know I get asked this question from women who are past the menopausal mess, but they're recognizing that they have family history of Alzheimer's. Now we're seeing the research, thanks to Lisa Mosconi and Roberta Britton, about how estrogen helps women with that risk, certain women with that risk. And so that's a question I get asked often is, for my brain health, can I start taking estrogen now? So I don't know if that changes anything.
Right. So let's talk about brain fog to start. So that's definitely a known problem in menopause. And by that, I mean difficulties in learning, verbal memory are common. And people who have brain fog, you can tell me, you know what I'm talking about. And the timing of the changes does suggest that it's linked to hormones as well as other neurochemicals during the menopause. Um, but if patients have this type of cognitive dysfunction, we don't know if that puts them at increased risk of dementia because most people with brain fog in the menopause will not end up getting dementia. So
Phew.
I want to make that clear.
I think
Yeah.
we need to say that again.
Um,
I can see that's going to be a quote on my social media from you. I can feel it. I can feel it coming.
all right. Dementia at midlife is very rare. And I'll give you a figure. It affects about 293 per every 100,000 women globally. It's interesting that you mentioned, like estradiol in particular, menopausal hormone therapy in general. It might confer a benefit in perimenopause with respect to brain fog, but most brain fog lifts, by the way. We don't know if taking hormonal therapy decreases the risk of dementia down the line. I think we need more data before we can make that definitive conclusion, Dr. Lovely.
Okay. Well, you've said something that I want to touch on. I keep hearing, I'm going to make some assumptions about you, so please excuse me if they end up being incorrect. You appear to be the wise woman, as in the menopausal wise woman. And I keep hearing it gets better. So please tell me, if nobody else, that the shit gets better. Because I need to hear it.
So I'm in the late menopause, postmenopausal phase, and I would say yes, indeed, it gets better.
Oh, thank God. Oh, I keep promising my husband it gets better too. He's like, I don't know, it's been going on a long time. I often say, if you don't know if menopause is affecting you, ask your partner.
Right, exactly.
It makes a big difference. Well, I have loved this conversation. You have brought me to tears a number of times. I didn't expect that today. I just it's so enjoyable to be in your company, and I thank you for being so generous with your time and your information and sharing with the listeners.
Thanks for the opportunity, Dr. Lovely. I really enjoyed talking to you too. I'm learning
Yes.
about a bit about functional medicine and about what you do.
Yes, a little tiny bit, really. This is, oh man, you've shared so much wisdom and I love it. Now, where can people find out more about you, Dr. Jacobson?
They can go to helloalpha.com. Also, we have an Instagram handle at helloalphamd.
MD, yep.
And then if you just search me for my LinkedIn profile, Mary T. Jacobson, MD Alpha, I think that you'll be able to find it.
Okay, awesome, awesome. So, for those who listen to the show, you guys know I like to ask my guest final question. I ask everybody the same question. Don't worry, you don't need to be prepared for it. So, knowing what you know now, Dr. Mary Jacobson, what would you tell your younger self?
Listen to the patient. It's important that you understand what's in the textbook and the clinical studies, but the best teacher is the patient.
Ugh, tears again. Damn it. I didn't know I needed a Kleenex sponsor for this episode. Dr. J, thank you so much.
Thank you, Dr. Lovely.
The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.